Hello, I'm Dr. I-Chen Wu, a gastroenterologist from Kaohsiung Medical University Hospital in Taiwan. The title of our report is Enteral Nutrition and the Quality of Life in Patients Undergoing Chemoradiotherapy for Esophageal Carcinoma, a comparison of nasogastric tube, esophageal stent, and ostomy tube feeding. Supportive care, including maintenance of enteral nutrition during chemoradiotherapy to avoid treatment interruption, is very important. Some experts advocate routine ostomy tube placement in all esophageal cancer patients undergoing chemoradiotherapy because chest pain and dysphagia often worsen. However, adverse events are not uncommon, and some patients rarely use the ostomy tube feeding. Moreover, many Taiwanese refuse prophylactic feeding ostomy creation. According to a survey in Taiwan, the top 3 reasons for their refusal were: first, inconvenience for a bath or shower; second, dislike creating a hole in their body; and third, they thought an ostomy is prone to infection. Esophageal stent is another way to keep oral diet intact, but I observed that some patients using esophageal stents suffered from intense and prolonged pain during and after chemoradiotherapy. I discussed this with our colleagues, but some of them were not convinced. At that time, little evidence was available about the feasibility of esophageal stent during chemoradiotherapy. If we don't use ostomy feeding or esophageal stent, how do we maintain enteral nutrition when symptoms worsen during treatment? As an endoscopist, my opinion was to carefully evaluate the location, length, and the severity of stenosis from esophageal cancer before treatment. If an ultra-thin scope can pass without resistance, we may insert an NG tube directly or under endoscopy guidance on an as-needed basis. NG tube feeding may be less feasible if the tumor is too long, located in the cervical esophagus, or if the patient has strong gag reflex, because tube kinking or dislodgement is likely. Since no study has compared the 3 routes for patients undergoing chemoradiotherapy, we launched a prospective cohort study in 2012 to compare esophageal stent, NG, and ostomy tube feeding. We carefully recorded their symptom, quality of life change, and monitored the nutritional status, including serial body weight and albumin change across treatment. During the recruitment period, more evidence recommended against metal stent insertion before radiotherapy. Our interim analysis also revealed worse outcome using esophageal stent. Therefore, we stopped further recruitment into this group. Our results suggest that esophageal stent may be less feasible in patients undergoing chemoradiotherapy. We also provide evidence that NG feeding is simple, safe, and as effective as ostomy tube feeding during chemoradiotherapy. In conclusion, we suggest a careful endoscopic evaluation to select the population more appropriate for NG feeding on an as-needed basis. Physicians can explain the advantages and the disadvantages of both routes so that patients can make their own choice. As for the future work, a multi-center randomized control trial is necessary to compare the transnasal and the percutaneous routes in patients with stenotic esophageal cancer who are scheduled to undergo chemoradiotherapy. Please read the manuscript and contact us if any questions or comments. Thank you.